Good afternoon. My name's Harry Hyman. I'm a faculty member at the School of Public Health, and I direct our DRPH program. On behalf of the Grand Rounds Committee and the School of Public Health, it's my pleasure to welcome you to this afternoon's lecture. The Grand Rounds Lecture Series brings nationally recognized thought leaders to Georgia State for dialogues that contribute to our mission of solving contemporary and emerging public health problems to improve health and advance health equity. I would be remiss if I didn't acknowledge the particular challenges we face in public health at this moment in time. If you're wondering how we in public health can meet this moment, I expect that what you will hear and learn from our speaker today is a powerful answer. Dr. Natalie Hernandez-Green is not only a deeply valued and respected colleague and friend, but a true champion for health equity. Her work provides critical models for meaningfully engaging with communities and diverse partners in research, public health and clinical practice, and policy advocacy. She's an associate professor in the Department of Obstetrics and Gynecology and the founding and executive director of the Center for Maternal Health Equity at Morehouse School of Medicine. Dr. Hernandez-Green received her master's in public health from the Rollins School of Public Health at Emory University and her PhD in public health from the University of South Florida. Her work focuses on eliminating women's health inequities through a multi-sectoral and multi-level translational research approach. She has both an extensive research portfolio and speaking schedule, so I'm particularly grateful that she made time to join us today, and I will say especially today. Please join me in welcoming Dr. Natalie Hernandez-Green.
Dr. Hyman forgot to mention that he also trained me to be as vocal as I am on these days. And I guess the buzzword today is equity, which might get me in trouble. So let me go with my funding disclosures. So this is all the funding that I receive from the National Institutes and HRSA. And again, the content that I'm going to speak on today is my views and doesn't represent the views of the National Institutes of Health and the Department of Health and Human Services. But before I begin, I always like to talk about my positionality and why I do this work and how I do this work. Here, there are three different pictures. The one in the middle is the projects I grew up in the South Bronx. On the left are my two children, and on the right is what represents me as a person. I am an Afro-Latina mother of two who grew up in the South Bronx, which is one of the poorest counties in the United States. My lived experiences, along with my training in anthropology and public health, deeply influence my worldviews in the way I frame research questions and conduct studies. Many people in my family have died prematurely from preventable causes, and you'll hear about some of those preventable causes of maternal health today. Many people, and most of the women in my family have had preterm births, and my sister is a maternal near miss. These personal experiences is what drives me and my commitment to addressing health disparities and improving community health outcomes. And my mission in life is to bridge the gap between research and real-world impact, advocating for changes that promote health equity and social justice. Why I got into this work. I remember having my first child and going through postpartum depression and thinking, oh my God, this is the worst thing and no one sees me and I feel very alone. And I was nursing my child, I kept seeing these headlines. Nothing protects Black women from dying in pregnancy and childbirth. A death of a Black mother, like it didn't matter what education, what income status, Black women were still dying at higher rates than other communities and populations. And I wanted to get at the root of it. And I knew it had something to do with my own lived experiences growing up in the Bronx and then coming here to Atlanta, Georgia. I kept seeing over and over these headlines, and I had a deep frustration with the glaring inequities in maternal health outcomes, particularly for Black women. And despite growing awareness, the existing efforts fell short. They were fragmented and insufficient, and were just really clinically focused and not thinking about other things that influence health. So where are we? The United States has the highest maternal mortality rate among high-income nations, with Black women, which is that far bar graph. Look how high that is compared to other nations. Despite being one of the wealthiest countries and spending more in healthcare than any other nation, maternal health outcomes in the U.S. lag significantly behind. The U.S. healthcare system, policy differences, and maternity care deserts where residents have limited or no access to maternal health care is among the factors that are really driving our U.S. maternal mortality rates. The U.S. and Canada have the lowest overall supply of midwives and OBGYNs to care for pregnant and postpartum women, with only 16 and 13 providers per 1,000 live births. And in Canada, the maternal death is estimated to be about 8 deaths per 100,000 live births, but in the US, you see that that number is significantly higher. And more than 2.2 million women in the US of childbearing age live in maternity care deserts. And we see the same things again with inequities by race and Hispanic origin, with Black women still having high rates. And although maternal mortality rates have gone down because we did have a spike with COVID-19, it hasn't gone down as quickly for Black women and birthing people. They're still 3 times more likely to die from pregnancy-related causes. And this disparity widens in different cities. In Atlanta or Georgia, the rate is almost 2 times, but in a state like New Jersey, Black women are 8 times more likely to die from pregnancy-related causes. And pregnancy-related deaths recently, prior to, in previous years, cardiovascular health conditions were the leading cause of pregnancy-related deaths. After COVID and the context and the environment that we live in, we see mental health conditions as contributing more to the causes of maternal mortality and severe maternal morbidity. Again, this was exacerbated by COVID-19, but we also feel that sub-stigma has been removed and more women are talking about mental health. And in the umbrella of mental health conditions, you have overdose deaths, death by suicide, as well as significant mental health conditions. And then for Black women, when you isolate that, the maternal mortality rate for Black women, a lot of the excess maternal mortality rate is different. It is more related to cardiovascular disease. And I have the citation there if you're interested in this article. It showed that, the rates for preeclampsia, postpartum cardiomyopathy, and complications of obstetric surgery were 5 times higher for Black women. And again, those leading causes of deaths were really concentrated around cardiovascular disease. And you hear a lot about maternal mortality and maternal deaths. What you don't hear enough about is severe maternal morbidity. And severe maternal morbidity is when a woman suffers from a severe obstetric complication from birth, and that can happen within a year of giving birth. And for every maternal death, it's estimated that it's 50 to 100 women, but colleagues from the Boston University have stated that this is an underestimation of what it really is, and they're presuming that for every maternal death, there's probably 1,000 women that suffer from severe maternal morbidity. The same inequities we see in maternal deaths are the same that we're seeing in severe maternal morbidity, where Black women are 2 to 3 times more likely to die to suffer from severe pregnancy complications. And this just shows that maternal deaths are only the tip of the iceberg. In the good old state of Georgia, Georgia is considered one of the most dangerous states for pregnant women and people. It has the highest pregnancy maternal mortality rate of all states, with Black women experiencing a rate of almost 3 times that of white women. And factors that contribute to this, I show a picture of a hospital closing, but almost every single day I get an email or we get reports of a hospital closing or some type of facility closing, particularly in our rural areas. We have unacceptably high rates of reproductive age women without health insurance. That's about 20%. The low proportion of reproductive health needs being met by publicly available health services is 16%. A low proportion of women with a dedicated healthcare provider, that's 66%, and one of the lowest rates of attendance of postpartum care. Additionally, we have high proportions of households living in poverty. That certainly plays a role, and 35.2% of the counties in Georgia are maternity care deserts. 76% of counties have no hospital or birth center offering maternity care. And what's more interesting about this is that most of the closings that are happening are in more Black rural communities, and there are actually more clinics opening in white rural communities. So we do see, this word is, a dangerous word to say these days, a lot of inequities happening in the state of Georgia when it comes to healthcare and available services. So what are the contributors to maternal deaths? According to the Maternal Mortality Morbidity Report, which no longer exists right now, some of those major contributors are chronic diseases. We have seen, higher rates of obesity, diabetes, and heart disease. We also know that, women are delaying getting pregnant, and so age is certainly a factor. The older you get, what people consider advanced maternal age, it increases you have a higher likelihood of experiencing some type of complication. C-section rates have also increased. We know there are a lot of hospital closings, again, different complications or situations that lead to more C-sections, and substance abuse and mental health, as I mentioned before, are leading causes. But that doesn't explain everything. We also know that the reproductive health of Black women has long been compromised by interpersonal, institutional, and structural racism. In addition to contending with social and economic drivers of poor health that undermine Black Americans, they've also experienced discriminatory healthcare practices and abuse from slavery to the present, from non-consensual medical experimentation to failing to listen to Black women and their complaints, to the medical experimentation of enslaved women, to practice gynecology. All of this has contributed to what we're seeing in terms of inequities, or can be contributing factors why we see inequities with maternal health. The history of racism in the United States, although people want to erase it, it exists. It exists today and existed before. And it's painful, right? We promoted birth control among low-income women as a condition of social welfare programs. We've created a lot of obstacles for people to have access to the care that they need. Historical and economic forces, including restrictions on housing options, job and education, the breaking up of families, have entrenched women who belong to racial and ethnic minority groups in cycles of marginalization and inequity. And this is that web of causation. People talk about social drivers of health, but it's really a lot of the policies and that contribute to what those structural inequalities are. And this is a really great piece by Dr. Joy Creer-Perry and colleagues on what that web of causation looks like. And I'll give you an example, because someone says, well, what is that, right? Because the social determinants of health are not protective factors for Black women. For instance, people say, oh, well, it's obesity. Black women are more likely to be obese. Well, in fact, Black women who are of normal weight still have worse maternal health outcomes than all women of all racial and ethnic groups who are obese. Black women have worse maternal health outcomes Black women who are educated, have a college degree, have worse maternal health outcomes than white women who drop out of high school. And so when we're talking about this web of causation, those are exactly some of the factors that are contributing to that. Another hypothesis that people talk about is the weathering hypothesis. This is the impact of high-level chronic stress caused by being a Black person in a racist society. The term weathering refers to the constant stress of racism and how that leads to premature biological aging. So for instance, they say Black women's bodies internally are about age 7 years more than white women. And there's a lot of research. Geronimus is one of the people who have done this research. We do have colleagues at Morehouse School of Medicine that are studying a lot of these biological markers and seeing how stress and weathering can impact health. And it's not that every Black person has more damage than every white person. It's really about how much stress versus social support you get in your everyday life. But because African Americans and low-income Americans are more likely to suffer from more of these stressors, they're more likely to be weathered, and they're more likely to be weathered severely. There's also, and I know this working at a medical school and actually going through this textbook, that there's bias in training. This bias is ingrained from the very beginning of medical training. There was a 2016 study of 418 medical students at the University of Virginia, and it revealed that more than half of them endorsed at least one myth about physiological difference between Black people and white people. 2016, not too long ago. And this is one of the textbooks. There was this really great study done by Smith et al., and they saw the commonly used textbook in obstetrics and gynecology had these imageries, and Black women were often depicted the way it is here, almost animalistic, and their faces were always shown. When white women were portrayed, their bodies looked exactly like this, and they actually covered their faces. So, what is the Center for Maternal Health Equity? The idea for the Center for Maternal Health Equity took root in 2019, and it was, again, born out of a deep frustration from me with the glaring inequities that I saw in maternal health outcomes for Black women. And again, despite growing awareness, things fell short. And I knew something had to be done. And so this is where policy comes into play. We had developed this maternal mortality stakeholder group, and we wanted to figure out solutions. And one of the things is, what people kept telling us, well, you don't have enough data. Where's the data? Show us that there are inequities. And so we advocated for a center. I modeled it after National Institutes of Health center grants, where you have a training core, you have a community engagement core, and research projects that will fall under it. And presented this idea to our legislators, and we got it funded, although it was a hard battle. We won, and in 2019, the state appropriated funds to establish what they call the Center of Excellence in Maternal Health Research. And we also knew that if we wanted to address inequities, it had to be at a historically Black college. And so that was one of the ways in which advocates, went to, the Gold Dome and advocated for this. Then I became interim director in 2020, and 3 days later, the whole world shut down. And so I had to lead the center in the midst of a global pandemic and remotely teaching a 5-year-old and a 3-year-old. But here we are today. Our center is a nationally recognized center. We do our work in 3 different ways. Of course, research. We wanted to make sure that we were providing the evidence to support anything that we wanted to advocate on behalf of or inform and activate the power of our communities with the data and the information they needed. We are at a medical school, and we do have colleagues affiliated with the center. We work on translational research from very basic science, where we have our colleagues, Dr. Erica Johnson, who's studying the impact of racism and looking at inflammatory responses in the placenta, all the way to population health. I'm a behavioral scientist and do that type of research. We also have developed and tested interventions, and I'll talk a little bit about some of those programs. One of the things, too, is that we often talk about community engagement, but I feel that sometimes that word is superficial. what I like to call it is community building, because we're in the business of building bridges and working together. And a lot of this is around amplifying and centering the lived experiences of our communities and making sure that they're informing the work that we do at the center. And so our community members and partners are really at the heart of what we do. And then, we have to think about the next generation of leaders and researchers. And so we do a lot of trainings. We've developed our own trainings, including a program I'll talk about today, our community-based perinatal navigator program. And we have 2 people in the audience that have been through that program and work with us, train to trainer, and really thinking about interprofessional education, because we were tired of people continually to work in silos, and we knew that we had to change the way people work. So that's a little bit about the center. We have been highly successful in the 5 years that we've been in existence. The state gave us seed funding of $500,000, and they turned that into $26 million in 4 years during a global pandemic. But this money is not for us, and it's not for our institution. It's for our communities and the work and the value that we place on our communities. And so a significant amount of our funding goes back into the community. So I'm going to talk a little bit about projects that I'm really committed to and really excited about, and today are becoming very controversial. So look at that name, the Center to Advance Reproductive Justice and Behavioral Health Among Black, Pregnant, and Postpartum Women and Birthing People. It's so woke. This mission was forged through years of meeting with multiple community partners who are really committed to supporting Black maternal behavioral health and with Black women with lived experiences. We held various meetings throughout the existence of the center, and again, one thing that kept rising to the top was mental health challenges. Black women are being ignored. There's a lot of stigma in our communities around mental health. We saw an increase of overdose deaths among Black women, and again, that wasn't getting attention. And then, death by suicide. And so in partnership with my colleagues at Emory University School of Public Health and the School of Medicine, we decided to come together along with our community partners and establish this center. We're one of the 12 centers of excellence in maternal health research funded by the National Institutes of Health, and we're one of 2 HBCUs that receive this funding. Really, our mission is looking at the intersection of the 3 gravest public health threats confronting the 21st century, which is the maternal morbidity and mortality epidemic, the behavioral health crisis, and racism. We achieve this mission through community building, and so we have a community partnership core that hosts about 60 Black-led community-based organizations throughout the country, with the majority here in Georgia. We have a research project. We actually have 3 research projects, but 2 of our projects were cut due to funding cuts. And that one is focused on looking at the way laws are implemented governing Black women's use of drugs and alcohol. And then, again, building the next capacity, the next generation of investigators, and building their capacity to be able to continue this work. We're going to have pilot projects coming out. We've been presenting some of this work. We have 3 fellows, and we'll be looking for visiting scholars. In the center, what's really nice about this funding mechanism is that most NIH grants are funded for 5 years when you have a center grant, but this one was funded for 7 years. So we've had a year to plan, expecting some of the challenges that we might have received this coming year. And then alongside of that, HRSA became woke and decided that they wanted to fund minority-serving institutions and put this call out. And so we modeled it pretty similar to Coral, but with a focus on rural communities. As I mentioned, a lot of clinics were closing in rural communities. Black women in rural communities felt really unheard. They felt like so many resources went to Atlanta, and they were sort of being left behind. And so we wanted to do something to really amplify and center the rural experience. And again, as you can see, there's a theme, right? A lot of our work in engaging with communities is what's informing all of our projects. So this has pretty similar goals, except we are doing more secondary data analysis and thinking about creative ways in doing that work, holding community listening sessions in 5 of the 6 perinatal regions in the state of Georgia, and with an emphasis on fatherhood, because we also knew that Black fathers were being left out of the picture. And so taking some of our evidence-based work and translating that into men and having engaged men, fathers, those who also have lost loved ones to maternal deaths in this process. And so we do have a small pilot sort of efficacy trial looking at if we also trained men to do not just be patient navigators, but also do group-based prenatal care, addressing a lot of the issues that are specific to men in this case. Another project, which I'm super excited about, is Project Impact. Again, those of us in public health know we love acronyms, and we have long titles. But here, the funding mechanism was looking at how do you take evidence-based interventions and implement them in community-based settings. And we knew that if we were going to tackle the maternal health crisis, we needed to do it before people got pregnant, because once people are pregnant, it's already too late. And we also knew with the statistics that I've reported that there's a significant amount of people in the state of Georgia, and particularly in the Southeast, where 53% of the African American population live, did not have access to healthcare. And so how do we deliver that to them? They're not going to a clinic, they're not seeing anyone. And so we took preconception counseling, made it culturally relevant to our communities that we serve, and are implementing it in community-based settings. This project had a phase 1 and a phase 2. Phase 1 was really figuring out from the community, and again, their lived experiences, what are they prioritizing, what do they want if we were to deliver something like this for them, and then thinking innovatively. So if a community-based organization was to implement something like preconception counseling, what would be an easy mechanism for them to do it? And so we did use what people know as ESPERT to be able to deliver preconception counseling using that sort of model. And then, again, doing some follow-up interviews. All of that, phase 1 was a planning year to then now take it to the next level, where we're conducting a hybrid type 2 effectiveness implementation trial with 10 sites serving low-income women, Black women and men in Georgia, North Carolina, and South Carolina, and we're hoping to also be in Tennessee to continue this work. It's a pretty big trial. We have a pretty big team working on it, but we've just seen amazing things and amazing community engagement and building strategies that have come out of this project that NIH wants us to always present on and implement across. And it is also being led by an amazing graduate of Georgia State University, Dr. O, who just came in. You see, I got to shout out GSU. Another project, this is phase 2 of a storytelling project. As some of you may know or not know, I was trained in anthropology, and so my heart is in qualitative research. I'm also a storyteller. My kids say they're storytellers. I think in communities of color, stories are our life's blood, right? We like to listen to stories, and it's through stories that we make sense of the world, that identities are shaped, and that we attempt to communicate what really matters to us. And so in working with community, we knew that if we were going to do research, we had to start with listening to who they were. And so phase 1 of this project, we collected around 170-something stories of women of color across the United States to hear about their experiences almost dying. I sat on our state's maternal mortality review committee, and I remember sitting there and be like, man, it's a shame that, we're reading these medical reports and then they're interviewing family, but why aren't we interviewing women who almost died? I think we can learn so much from that. It can influence policy, it can influence interventions, it can influence healthcare strategies. And so that's exactly what we did, and that was our first project in the center, and that led to the research agenda you're seeing today. But something was missing. We knew that we wanted to gain a deeper understanding and listen to fathers and support persons and physicians, because they have a story to tell too in this experience. A lot of physicians have been villainized. But think about being a Black OBGYN and practicing in a racist institution. There's some barriers for that too. And then the other part of it was also in working with colleagues like Charles Johnson and Wanda Irving. You know, they wanted to know what would happen to their children without their mom. And we're seeing that now. And so we've been interviewing adults who have lost their moms to a maternal death and seeing what their life trajectory was like. Every other country is doing this except the United States. And so we took on that big, hairy, audacious goal of trying to interview people around that. And so the objectives of this were really to, again, figure out maternal near misses across these different stakeholder groups, create educational campaigns. And so we've held brunches, hear and share sessions, community sessions to engage in meaningful conversation and hear what the community has to say about developing interventions or what it is that they need in their communities. Also being in a medical school and being an educator, we wanted to be able to use these and turn them into case studies, and so we can have meaningful dialogue and conversation about it. And then my favorite thing is informing policy strategies, because all of this work is band-aids. If we don't take it to the next level and change systems, then we'll always be at the same juncture. And so it's important that all of our work that we do at the Center for Maternal Health Equity somehow informs policy strategies, or we arm our community organizations to go out there and advocate with the information and the evidence and data they need to advocate. So I did have a clip, but it's not going to play on here, but I will read you a quote from one of our navigators, and now I can't even find that quote. Anyway, what I'll do is I'll summarize, and I'll also send the links. NPR featured a whole series on this project, and the New York Times, and so we do have those clips from that. But I'll tell you a story that we did here. There was a woman who, and I always title this presentation, I Woke Up 10 Days Later. And she had HELLP syndrome, and no one knew that she had that. And she said the last thing she heard was, "You have HELLP, you need to sit down," and she blacked out. And she woke up 10 days later. She was in a coma for 10 days. And when she woke up, she said, she felt heavy, and she thought, it was all the stuff, and the, blankets and everything. And she not only almost lost her life, but she also lost her child. And she is a lawyer, educated, kept telling people, and she said she was never listened to and felt like no one heard what she was saying, like she was dismissed. This was her 4th time coming to the hospital and people turning her away. So it's stories like that that we heard over and over again. And I know my staff is traumatized by analyzing a lot of these interviews, but it was really important for us, although it was hard to get through, that again, that that people's lived experiences are legitimate sources of data, that you can have people provide that data. We function in white supremacist ways of this sort of quantitative paradigm, when that's why we haven't been as effective in delivering interventions and giving people what they need in the amounts that they need it in the ways that they need it. And that's what equity is all about. And here is my baby, literally, the community-based perinatal patient navigator program. I, prior to maternal health, was doing, I always did women's health. I was really focused on the human papillomavirus and cervical cancer. again, that was really personal to me. I knew a lot of people who suffered from cervical cancer, and particularly when I worked at a civil rights and advocacy organization with the Latinx community, a lot of women were getting diagnosed late and, dying from something that's so preventable. We have vaccines, we have pap smears. But one thing that we saw that was working in cancer was patient navigation. And what made it so effective was that it was being delivered by their peers, by people who had those same lived experiences of going through a cancer diagnosis and treatment. And I was like, well, why isn't anyone doing this in maternal health? Like, this is something that's low-hanging fruit, and we just have such powerful people in our community. If we give them the tools, we can activate that power to be able to do something about it. And so we developed this community-based perinatal patient navigator program. And it works by people doing an assessment. We're really focused on the unmet social needs of our communities. Then they connect patients with resources. Some of them have, or all of them have been trained as doulas. They can choose to also provide that social support as a doula to their clients. A lot of health education. So they have individual sessions and then hold group health education sessions with community members. And a lot of this is to really activate the power of our communities, right? Because sometimes, we're trying to be so innovative with AI models and developing mobile applications, which I also developed and have a patent for, but that's besides the point. We're trying to be so extreme with how innovative we want to be that we forget that women just need to be listened to and supported in meaningful ways. So to me, that's innovation. And then we're seeing improved health outcomes. And I love pictures, and so I like to show our different cohorts. That's our first cohort, which was in 2022. And then we've had one in rural South Georgia in the Albany area where we trained a whole cohort. We had one, this clicker is not working with me. Another one here, and then our most recent cohort here. But we can't stop there, right? Because then everyone's like, that's a cute program, but does it work? And so we applied for an R01 with some colleagues from Emory University to be able to demonstrate not only effectiveness outcomes, but also process evaluation outcomes. So if someone wanted to replicate this, what would that look like? And what can we improve on with this program? And so again, another acronym, VOICE. You see the equity word there again. So guess who's really worried today? To perform a pragmatic trial looking at these different outcomes. And so we're discerning effectiveness towards severe morbidity and severe maternal mortality, improving access of unmet, are we meeting the unmet social support needs of our communities? And are women going to more of their appointments? And then again, with process evaluation, looking at reach, dose, and fidelity, how people are implementing the program, perceptions from healthcare providers, which we're already getting such great reviews from our colleagues at Grady, where this is based in. And then we're also at an FQHC, Atlanta Birth Center, and Morehouse Healthcare. And so I have some interesting and cool data. It's more descriptive statistics, but it just gives you, some insight on what people are experiencing. And so the median age or the average age of people that are participating in our intervention are 27. And a significant amount of them that enroll, which I did suspect are first-time moms, right? The first time that they're pregnant. What really stood out to me were these participant unmet needs where, people are really worried about housing. We hear from our navigators that a lot of people don't have the housing that they need. But what really hurt me to the core was to see how many people are worried about food. To see 61% worried that it would run out. And that 58%, particularly in the intervention group, felt that the food did not last often, really struck something with me. And then again, you just see people having significant challenges with their utilities, transportation, and then here, stress. We have had so many people where we have to alert their providers that they're suicidal, and they're dealing with a lot of emotional stress and are, just, it's just heartbreaking to see what women are experiencing. And this is just a snapshot, right? These are just one research project where people are experiencing this in our communities. Something else that we felt the need to do as a medical school was develop a rural OBGYN residency program. Half of Georgia's counties, I mentioned before, have no OBGYN provider. And we know people are driving miles, an hour, 2 hours just to get to a provider. And so, we spoke to the state to get additional funds to be able to recruit people in rural communities to be able to practice. It's not there's one solution. I think there's a way for, like, I'm interested in family medicine and training family medicine docs to be able to do fellowship in OBGYN. And, having, a track for maternal fetal medicine docs in rural communities. But, it's one little seed that's being sown, but I think it can go really far. And we do have our rural resident who's in Albany, Georgia, Phoebe Putney, but travels because people are like, oh, Albany's not rural. No, she's going to all the clinics in these small counties, helping residents, and people are really excited. Just for some perspective, there are 4 OBGYNs in Albany, Georgia that serve all of the surrounding counties, and all of them are over the age of 65. And then, again, we kept hearing, oh, I felt not listened to, I was treated disrespectfully. And so we created a respectful maternity care simulator. Our colleagues in the Department of Obstetrics and Gynecology, Dr. St. Louis, got funding from us and Teaching Society for Professors of OBGYN to create this respectful maternity care simulator. Respectful maternity care maintains women's dignity, ensures that their privacy and confidentiality are protected, and enables them to have informed choices. And there are a few evidence-based approaches on how to do it. I think like March of Dimes, there are a couple of organizations that have these type of simulators, but this was really, again, informed by our own community, informed by the providers' lived experiences. And so we've had a pilot on this at Grady because that's the hospital that's associated with Morehouse School of Medicine. And we're expanding that pilot in the next 2 years to be with nursing, with outside of Grady, with other facilities. We've actually been invited to Tennessee to do this respectful maternity care simulator, and we'll have more different types of simulations with our new case studies that we'll have. And so providers go through, some information, they watch these videos, then they emulate what they experience, they practice it, and we do a pre and post test. And we've seen significant strides in how providers are now being more thoughtful about how they're approaching patients. And so we've had a lot of success stories with this approach. As I mentioned, this clicker is really sensitive. As I mentioned before, one of the ways we're going to be really to achieve a lot is through community building strategies, promote maternal health. This helps create awareness. We work with, a population where literacy is a huge issue. We've taken some of our information that we had at a 6th grade reading level and had to put it at a 3rd grade reading level, particularly when we go into some of the rural communities that we're engaging with. And this is something that's, again, at the heart of what we do at the Center for Maternal Health Equity. We make sure that information is accessible. The belief behind community engagement is that the people impacted by the problem have some of the best solutions. And they help us to understand how they experience the system, how their lived experiences contributed to particular outcomes. And so, again, I always highlight this as nothing, again, fancy or innovative, but it's really at the core of what we do, and I believe that a lot of people should be doing. And then getting the word out about who we are, and ensuring that we're reaching all types of medians, right? So in academia, it's usually going to American Public Health Association conference and presenting your findings, and then no one else knows about the incredible work you're doing, and it's not reaching the actual community who should be knowing about the work and the resources that are available to them. And so we take an approach where, yes, we still do the academic stuff because I cannot get promoted or get paid what I want to get paid if I don't produce peer-reviewed publications and grants. But then we also, again, work and inform policymakers. So we had an opportunity to go to the Congressional Black Caucus Foundation Conference, different types of policy conferences, the National Medical Association. I've done the Washington Post Live series, just really being out there. And one thing that I have, that we've done a couple of times, but I want to institute, our Friday night insights. And so like Georgia's big on high school football, and you think about Friday night lights. And so what we wanted to emulate was Friday night insights, to be able to engage with community, provide dinner, because we know food insecurity is a big issue, and just have meaningful conversation together. So what can I do as a student, a colleague, and I was able to meet with some of the scholars earlier, and I was able to be myself. I hope no one recorded anything I said. I said it was off record in that room, but there's so much that we can do. And this is a picture of Wanda Irving, who lost her child, Shalon Irving, to a maternal death. Shalon had two PhD, Hopkins, studied equity, and found herself in a situation, and she's no longer here. Although she complained to her OBGYN and to nursing staff 4 times that something was not right. And she succumbed to a maternal death. And here's a picture of her mom and her daughter, Soleil, who's my sunshine because she thinks we're besties. But I always say, what can I do? What can I do to support you? And she always says, just show up. Maternal health inequities are not just health issues, right? They are systemic challenges that require multidisciplinary solutions, community-centered approaches, and a deep commitment to justice, because ultimately that's what we need to get to. So for students in public health who are passionate about addressing maternal health disparities, there are meaningful actions that you can actually take today to begin. You don't have to graduate with your master's or your bachelor's or your PhD to start doing something about it. You can do something today. You can engage with communities, partner with local organizations, birthing centers, advocacy groups, and advocacy groups need you more than ever. Understand lived experiences, especially in politically marginalized communities. Build trust and foster genuine relationships, and that's going to be key for you. Advocate for policy change. I am funded by the federal government, so I cannot do that. But I can give you tools and data so that you can advocate for policy change. As I mentioned, maternal health inequities come from systemic challenges. So stay informed on policies. Read your local newspaper, even TikTok has information. But there's just so much you can do. Y'all are right next to the Gold Dome. They're in session right now. Use maternal health awareness event days. There's Black Maternal Health Week. There's so many different events that you can go to show support and advocate. And you have Dr. Harry Hyman, who taught me how to be one of the best advocates and be strategic in how I work with policymakers. Lean on that. You have amazing faculty in this institution that are up there all the time too. Lean into the assets that you have within your own institution and enjoy every bit of it. Even though you feel like you're bothering your faculty, just email them again. Believe me, it takes like 6 times for someone to get through to me. But eventually I'll get to them because this is why I'm a professor, because I love engaging with learners. focus on cultural sensitivity, develop skills to be culturally sensitive to interventions that respect and uplift the traditions, beliefs, and voices of diverse communities. Maternal care is not a one-size-fits-all, and the research is not a one-size-fits-all. So be intentional about how you want to conduct your research. And as a researcher and someone who loves research, I should have known I loved asking my mom like a million questions. But explore areas. Look at areas that haven't been addressed, like preconception health, right? What can we do about that? Barriers to accessing care. What are current strategies that are happening? Why hasn't the state expanded Medicaid? What's going on, right? Understand that there are amazing advocacy groups like Georgians for a Healthy Future who are on the ground every day advocating for healthcare access for all. Think about community-driven models. How can we adapt them to fit diverse needs of different communities? Again, so much you can do. We're in public health. Public health itself is interdisciplinary, but go outside of this department, engage with people in psychology, with people in, urban development. All of that impacts maternal health or women's health or public health in general, education, social services. We're gonna all need to get together to address this public health crisis that we're about to embark on. And commit to lifelong learning. Attend seminars. Thank you for coming to this one. Workshops and conferences. Stay informed on emerging trends, innovative programs, and strategies for creating impact. You have power to be a catalyst for change by combining your academic knowledge that you're getting here and that we're so privileged to get with a commitment to equity and justice. You can contribute to a future where maternal health outcomes are no longer determined by race, income, or geography. And your dedication can make a difference in the world. Yep. So this is one of my favorite pictures. Oh, I can't get to it. So I don't know if any of you have been to the West Side and seen the Mother House. And this is a group of advocates where Black Mamas Matters Alliance started, Sister Love, amazing reproductive justice organizations. And I wanted to end with a powerful African proverb. If you want to go quickly, you go alone. If you want to go far, you go together. In the political and social context we face today, this quote reminds us of the urgency and importance of collective action. Maternal health inequities are complex and deeply rooted, and no one person, discipline, or organization can address them alone. We must work together, especially now, across communities, across sectors, and political divides to ensure that our most vulnerable communities are not left behind. So I want this to be a call to action, to move forward together, guided by compassion, determination, and a shared commitment to justice. Yes, I said it. I said justice. And only then can we truly go far and create lasting change. First, I always put pictures of my staff, although I need an updated one. But I want to acknowledge all of the work that they do. I have the most amazing team. I started the center with just 2 of us, and now there's 30 of us. And they mean so much to me. I feel like a auntie, a granny, a mama, all sorts of things, but they are truly my heartbeat. They get me going every single day when I feel so defeated in this work. And I just want to thank them even for showing up today. So thank you guys for showing up and supporting me. But I want to thank you all for coming today, and I hope that this was informative. I heard a few laughs, but I want us to remain vigilant and committed to this work. So thank you so much, and here's my contact information.